Landon was born in January of 2009. When I was pregnant with Landon, everything went great. After I had him, I started to have anxiety about something bad happening to him, and it was keeping me from sleeping. When I did fall asleep, I would be plagued with these nightmares of something bad happening to him. The anxiety just totally took over my life, and the insomnia got worse and worse.
So PMAD stands for Perinatal Mood and Anxiety Disorders. It's a larger group than what people previously would refer to as postpartum blues, or more correctly, postpartum depression. It's including anxiety. So this is very common. So it represents about 10 to 15% of women are going to have some symptoms related to this. Common things we're going to see with PMAD are going to be an overwhelming sense of sadness, withdrawal from their friends, difficulty sleeping, difficulty bonding with their baby.
People didn't quite know what to do with me. When I went to the ER, the doctor there told me that I needed to eat right and exercise, and he gave me medication called trazodone. About a week later, things continued to progress, and these images that I was having of my son being harmed, it turned to images of me harming my son. And I started to hear voices that were telling me how to harm my son and how to harm myself. And these voices would like taunt me. At that point, I had had no sleep for almost 7 weeks. I would sleep in just half-hour chunks, and each of those chunks would be a horrible nightmare where I would feel like I was not getting any rest at all.
If you look at the incidence of perinatal suicide in this population, it's much, much higher than the general population. But then as you trickle down to the more common abnormalities here, you have problems with the mother bonding to her baby, you have problems with the mother interacting with her baby that have been linked to long-term developmental issues for the child. So it's a big problem for both the mother, and it filters down, just as you would expect, to the baby. Dignity Health is tackling this issue mostly because we have a very large obstetrical population to deliver within our hospital, and women being seen in either pediatrician's office with their babies postpartum and antepartum. Overall, Dignity Health does about 60,000 births within our 29 maternity centers. So this is an opportunity for us to make a huge impact on a very large number of women that receive their health care within Dignity Health. The American College of Obstetricians and Gynecologists recommend that all pregnant women get screened at least once during the perinatal period, and many experts recommend that they also do it postpartum, particularly people that are at risk factors. And those that have risk factors that are identified in their initial screening should be followed more closely for PMAD.
The second time I went to the ER, I was evaluated by a mental health worker, and he was the one who identified, yes, there's something definitely wrong with her, and we need to help her by sending her to a mental hospital. After a week in the hospital, I was a new person. I felt so much better.
In the past, postpartum depression or postpartum mood disorders or perinatal mood disorders have largely been left to the obstetrician, who in many times don't feel comfortable in treating the patient for something that's a little bit out of their comfort zone. Part of the initiative within Dignity Health is to really take a more comprehensive approach. We want to involve all the care providers that are encountering the women or the infants. So this is going to include our obstetricians, our pediatricians, our family docs, our ER docs, but also the ancillary people that are critical for treating women with postpartum or perinatal mood disorders, or social workers, our nurse practitioners, other people along those lines. And then ultimately engage mental health professionals, psychiatrists and psychologists to help us move this initiative forward to treat this at-risk population. PMAD has therapies that work, and they're relatively easy to implement and put into practice. If you look at Christy's story, it's a classic example of how PMAD formed and how it went unrecognized, untreated, and evolved way beyond where it should have.
I was embarrassed of the things that I was imagining happening. Like, I did not want to describe those things to even my OB. It wasn't until I got prescribed medications from a psychiatrist that I started to feel better. I feel like at the 2-week mark, when I was desperate and on the phone calling my OB. I feel like if I had seen a psychiatrist or a psychologist at that point and they had been able to put me on some medications or maybe try some different medications, or at least see me every week to be able to follow up with me to see if I was improving, then I feel like that would have helped so much. I think one of the most important things that I heard in this journey was that it wasn't my fault. So I'm actually glad that we're calling it the perinatal mood and anxiety disorders, because I feel a lot of people probably don't feel sadness. They have other symptoms that go along with it, and I think anxiety is really something that people feel a lot of after they have a baby.
Christy's story really highlights why healthcare providers need to be really vigilant in understanding the risks and the symptoms and the significance of perinatal mood and anxiety disorders. Dignity Health, we'd like to look at this as a two-generation issue. Mothers that have symptoms of postpartum mood and anxiety disorders, we understand that it has a significant impact not just on the mom, but on her newborn, on other children in the family, and on the extended family as a whole. We are designing a program where we're able to screen every mom, every patient that comes into our facilities or interacts with one of our care providers. Our goal is to have a standardized approach in how we screen patients, patients that are identified to be at risk or are exhibiting symptoms of mood and anxiety disorders. Our goal is to get them the help that they need. We really are interested in providing, if we can, the resources, the interventions locally or at that patient's care provider office. If not, our goal is to do a warm handoff to those who can provide those services. Our overarching goal at Dignity Health really is to have healthier families and healthier communities. And if we're able to get those mothers and those families the help that they need, it really is going to have an impact on our communities.
So everyone was nervous about me having a second baby. When I did get pregnant with James, I talked with my OB about going back on the medications. I started seeing a psychiatrist again, and it was a night and day experience. It was a wonderful, wonderful infancy stage with James.